Scaphoid fracture used to come as a short note for undergraduate student, as well as all the treatment protocol and all the complication have to cover by our postgraduate resident. Now, before going in details for scaphoid fracture, you have to know the basic anatomy and blood supply. The blood supply of scaphoid fracture is critical. The radial artery, when give one palmar branches, is called superficial palmar radial artery. It has two branches, one dorsal, one volar. Now, by volar supply, it 70 to 80% of blood come through this volar part, and last 20% is supplied by the dorsal part. So volar is dominant here, not D. Not D is only 20%, but volar is 70 to 80%. But the peculiarity of blood supply to the scaphoid is come through the distal up to the proximal. And another peculiarity of scaphoid, it is a intra-articular bone, and this bone, 70% of the bone surface area is articulous bone, like talus. So if there is any fracture, the due to fracture and gap, there is a chance of secondary osteoarthrosis or any pain over the wrist joint occur. So the scaphoid fracture must be treated promptly, as well as the diagnosis of the scaphoid fracture mostly done clinically, then radiologically. The mechanism of fracture is fall on outstretched hand. Then there will be tenderness over the anatomical snap box. And on the radiology, if you want to prescribe AP and 45-degree oblique view, this is very important to diagnose the scaphoid fracture. Sometimes we cannot get so much displaced or so much clinically, and there will be a clinical suspicion, but radiologically you cannot get a proper fracture line. And for the beginners, the fracture line, to identify the fracture line is very difficult. So when you are suspecting a case of scaphoid fracture, means if his history of fall of outstretched hand followed by swelling over the anatomical snap blocks and severe tenderness, you have to think about the scaphoid fracture. You may see the fracture line, you may not see the fracture line, but if you have the clinical finding, you have to note it down and you have to plan accordingly. Now there are many types of scaphoid fracture, but three fracture is very common. One is for distal pole, one is of the waist fracture. This is most common, 70 to 80% come with this waist fracture, and one is proximal pole fracture. Now the treatment protocol for any suspecting case of scaphoid must be go for a splintage or scaphoid cast. This scaphoid cast must be done a glass holding fashion. Now this glass holding fashion means you can do it below elbow, but book teaching, that must be above elbow and up to this first distal interphalangeal joint, and in this position you have to ask the patient to hold in air. He will supposed to hold a glass, but on that position you have to do the plaster. Now the extent of the plaster in our clinical practice not too much aggressive. You can do it below elbow also, but you have to encroach the first thumb. That is important. Now duration of the plaster, for time of healing, for the distal part you have to give at least 6 to 8 weeks, and for waist you have to give at least 8 to 12 weeks, and for proximal pole you have to wait a long up to 24 weeks. You have to check it with a serial X-ray, and 95% of union rate can be estimated with this type of active management. Now, sometimes this Sacphoid facture has a notorious for non-union. So if we radiologically found that this Sacphoid fracture is displaced, then we have to go for operative fixation. Now a small treatment protocol, if it is displaced, then totally operative, no conservative. If it is not displaced, then we have to put a plaster cast for 6 weeks. Then you have to check x-ray, it is displaced or not. If displaced, then go for operative management. If not displaced, then again you have to continue 2 weeks of plaster. After that you have to go for physiotherapy. Sometimes after doing this proper plaster also, patient can go in non-union, then you have to go for operative management also. So when you are treating or doing a plaster in a in a Sacphoid fracture, you have to counsel the patient that this type of fracture has a chance of avascular necrosis of the proximal pole, as because is peculiarity of the blood supply, so there is a chance of non-union. Then it can goes in avascular necrosis, and all that you have to explain the family member, otherwise patient will blame you for the consequences. And regarding the operative treatment, we have to put a Hardbird screw. What do you mean by Hardbird screw? It has a different pinch, and this is the guide wire. This Hardbird screw used to put within the bone, and it has no head. It is called headless screw. Yes, no head, and that will be kept in this Sacphoid for whole life, no problem at all. And due to the different pitch, there will be a lag effect and compression in the facet, so fracture is not seen here after the operation, and it can done under CM guidance, and percutaneous operation is recommended. Now complication, in the long run there will be non-union. See, there is a gap, palpable gap, there is a significant osteolytic gap, irregularity of the fracture site smoothen up, and there is sclerosis in the fracture site, both sides. So this means this is and there must be history of fall, and clinically there will be pain in the Sacphoid fossa. After 6 to 8 months, patient came with this type of non-union. This is called Sacphoid non-union. Now if this patient was neglected for any reason, for then this portion will going further avascular necrosis. As a result, the articular surface will lost. As a result, the secondary weight changes of the wrist. This is the reduction of the joint space, osteophyte, and total collapse of this proximal pole, and this is called wrist arthritis. And this occur in the late cases. So most common complication is non-union followed by wrist arthritis. Now what are the best treatment for non-union or wrist arthritis? If we got a case of wrist arthritis and there is a proximal pole osteonecrosis of the Sacphoid, and we are not trained enough for doing a good operation, rather we can go for excision of the proximal part, and for for this gap we can put a beanbag like anatomical bursa. How? We can take a palmaris longus graft by MIPO technique, minimum invasive technique. Just nick here, I will put it a mosquito, hold it the palmaris longus, I will drag it, and there will be impression, and it will put the cut here, and the palmaris longus graft is ready. Now it will roll and make a bean bag, and it will put as a cushion. So the chances of further wrist destruction and further wrist pain will be decreased. Now another operation is Hernandez iliac crest bone grafting. This is a non-vascularized bone grafting. As we all know, the treatment of non-union is debridement of this unhealthy bone, sclerosed bone, and after that you have to put a bone graft. Here we have to take tricortical bone graft because this portion is articular. So iliac crest, this is called tricortical. This is one cortex. This is one cortex. This is one cortex. This is called tricortex. 1, 2, 3. Now this portion is very smooth, so it represents the articular surface of this scaphoid. So we have to do a, a, a open reduction. You have to do the osteotomy or removal of the sclerosed margin. Then we have to put it back and over this gap, and we can hold this only K wire, or we can put one hardware screw also. So in the long run it will help for union. This is called iliac crest bone grafting in case of non-union scaphoid fracture. But one problem is this: due to opening of this joint, there must be some wrist stiffness also and persistent pain, and you have to counsel. Now another operation is muscle pedicle bone graft. Here issue is non-union, so blood supply is less. As a result, if we can do a bone graft along with its normal blood supply, then it will be better than a non-vascularized bone grafting. See, we can take a bone graft from the distal radius, because this is the cancellous part and this is the area of ponator quadratus muscle, ponator quadratus muscles. Now we will take a bone graft along with some fibers of pointer quadratus and we will roll it back, and we will put into the gap after debridement of the non-union site, and we will put a hardware screw like this. So here advantage is we can get the blood supply. So the bone graft, it has a vascularity, so chance of union is more high. But the challenge is the operative technique. This operative technique need a long learning curve, so most skillful surgeon must go for this operation. This is called Mataru's technique. So this is all about scaphoid fracture. So I just give a small revision. When any type of fracture came, you have to start from the anatomy and its blood supply, then the mechanism of fracture, then the clinical findings, then the radiological findings, then the classification of the fracture, and here waist fracture is most common, and then the treatment protocol, and after that how many days you will keep the plaster. For distal you have to 6 to 8 weeks, for waist up to 12 weeks, and for the proximal up to 24 weeks. After that, when it is displaced or it is going to non-union, then you have to do a hardware screw fixation. This is a intra-articular fixation. This is a headless screw, defined pitch, lag effect, and other compression of the bone. The non-union and restart, that is the complication. Again we can go for salvage procedure in case of arthritis, palmaris longa stent graft, bean bag, then iliac crest graft, and then vascularized graft. Thank you.